Well, thank you everybody for joining in today, March 22. And the idea here was to, actually this talk was meant for our Tanzanian Medical Student Association, TAMSA. They had reached out asking us to prepare a session especially for them. I also welcome our colleagues from Kenya and Uganda, as far as I can tell there. I really want to thank Elton Mahulu and the other team that kind of reached out to me and others to help share some of this USMLE information and so forth. So my name is Dr. Frank Minja. I'm a neuroradiologist. A radiologist specializes in brain and spine imaging, origin from Tanzania. I'm based here at Emory in Atlanta, Georgia. You are seeing there a presentation by my colleague, James Ignas Kola, who is an internal medicine and preventive medicine physician based in Connecticut. I'm hoping he'll be able to join us later today in our talk. It's very early here in the US. It's about 6 o'clock in the morning Eastern time. So hopefully he'll be able to join us towards the end of this talk. So we're going to spend exactly 2 hours. I'm going to run through some slides for maybe 30, max 40 minutes. And the balance of the time, hopefully an hour or so, is going to be spent on questions and answers. So hopefully this is going to be mostly a Q&A session. I had shared with Elton several YouTube links that are online with this USMLE sessions 101, 201, and 301. And these are designed to explain the process of applying for graduate medical education in the United States, so otherwise known as residency. If some of you are playing on social media, you will notice that yesterday was match day, hashtag match 2025. That is when many of the medical students, both in the US and outside the US, found where have they been assigned for their residency training. That's a major, major milestone in the United States in terms of like your medical journey. So it's a really, really big deal because basically now you know where you're going to spend the next 3 to 5 years of your life getting some specialty training and so forth. But the great news is that basically there is a huge need for international medical graduates. So unfortunately, the United States does not produce enough of our own American medical graduates to kind of satisfy the need that is required here in the United States for training. So somewhere, Dr. Ignas has the numbers, but a huge percent, somewhere in like 40,000 of the people who matched yesterday actually did not train in the United States. I'm sure people can dig in specific numbers, but it's not an insignificant. So somewhere 40 to 50,000. So that's a massive, massive number of opportunity. And so our job is to make sure that our colleagues from Tanzania, Kenya, Uganda, and elsewhere have accurate information so they can be competitive for these training spots, which we really believe in. That is some of the best medical education on earth, if you will, because it's very highly regulated and it's very sort of modern and advanced. So I'm gonna share that information. Again, we're going to be moving extremely quickly. Ideally, you should have reviewed all of the videos before, so spend about 2 hours on any of those videos. You can listen to them in faster speed, so you can sort of catch up really quick. So that way, we can spend a lot more time here answering questions. Again, for those who are just joining us, we had asked that you rename yourself and add which year you are, whether you're MD1, MD2, I see here up to MD6, you know, which medical school and so forth. It can kind of help us understand what our audience is. So if you're able to do that, that would really, really help me. If you're able to put it in the chat, that also kind of helps us to kind of like understand who you're dealing with, so we can make sure that our talk today is providing relevant information. So without further ado, I'm going to go into our thing, right? So today we won't have the full team, but I will introduce the team later on. These are colleagues who are now training here in the United States at different levels. And so I want to make sure that, you know, you guys see examples, and sometimes seeing is believing. So we, you know, when we have these talks, we always make sure that we have several colleagues to be able to join us. But I anticipated this was going to be a closed group session, so I didn't really invite them, but they are in the slides and so forth. So first of all, why bother? Why are you wasting like 2 hours of your weekend time listening to all these talks when many people probably tell you, oh my God, it's impossible to get in, you know, that's like a pipe dream and so forth. You know, why waste your time? Some people tell each other, oh my God, it's too expensive. Why are you wasting your money and so forth? So there's a lot of like unfortunate misinformation. I don't know whether this is true in the Kenyan space, but certainly in the Tanzanian space, there's a lot of unfortunate misinformation and a lot of misinformation around discouraging each other, which is really stupid because people feel that if they discourage each other, they're increasing their own chances, which is really kind of like impossible for you to do. So we're here to kind of dispel some of those myths. Two, the real reason around all of this is to basically build a base and team that's going to help us move medical care in East Africa forward. So I really believe anybody who goes through the process of qualifying for graduate medical education in the United States is going to be a better doctor, right? No offense to doctors who are trained elsewhere, but what I'm saying is training here is very rigorous. So there's very little way for you to kind of make your way through the US graduate medical education without knowing what you're doing, right? So basically you will get fired. So basically if you're not keeping up, you're gonna get fired from this system. So our system here is a little bit brutal, but it's also very mature in basically being able to understand whether or not the trainee is progressing, whether or not the trainee is meeting milestones, and also whether the program is indeed providing what they said they're going to be providing, right? So our medical education is regulated, and it's heavily regulated. It's regulated by the government, is regulated by the university, is regulated by patients, is regulated also by the trainees. So the trainees also evaluate the programs, right? So you're coming into a system, an ecosystem, if you will, that is very mature in providing advanced medical education. So in your process of qualifying for medical education here in the United States, is going to make you a more knowledgeable doctor. A more knowledgeable doctor is a better doctor every single time. Whether you're in Atlanta, whether you're in Dar es Salaam, whether you're in Nairobi, whether in Eldoret, I don't care. The doctor who knows more is the better doctor, all right? So this is the whole crux of all of this stuff. So even if you do not come and train in the United States, the process of qualifying, right? The process of qualifying is going to train you to become a better medical doctor, right? So this also means it's going to make you a better medical student. So again, you're going to see towards the end here that we're talking about the first aid, you know, the USMLE first aid book and all of that. If you master that book, you're going to be a better medical student, period. I don't care where you're training, Pakistan, you know, Kenya, Uganda, it doesn't matter, right? So when you know your stuff, you're going to be a better medical student. So I really honestly believe in that. If you're a better medical student, you're going to become a better medical doctor. And then you're going to have the option, okay, the option of practicing whatever the hell you want to practice. You know, I don't want to come to the States. I want to go to, like, you know, United Kingdom. I want to go to Australia. I want to go to Germany. I don't care where you want to go, but I want to make sure that you have the information early on to make sure that you have the best chance to be the best doctor you can be. And that is an existential problem, meaning I would like to make sure that when I need a doctor, I'm being taken care of by the best doctor possible, okay? So that is also sort of like a selfish kind of thing, but right? So it's our job to make sure that you guys are super well trained. So when we begin to need medical care, we have people who are able to kind of like, you know, really give us like advanced medical care. So that's issue number one, right? And I'm hoping all of you are here, MD students or MD graduates, and want to become better doctors. And if you don't want to become a better doctor, that's like a whole nother like lecture. I could spend an hour on that. There are many things to do in the world. You don't have to be a doctor, right? So that's also great. But if you're here, my assumption is you are trying to become a doctor. right? And my assumption is also you're spending time trying to understand how to become the best doctor you can be. So that's the real crux of it. Everything else is extra, so if you come here, you get a really great job, you get paid, that's extra. If you go to work in a really beautiful place, that's extra. But the crux of the matter is when you have your patient, are you the best doctor for that patient? That is the crux of the matter. And that can only be helped one way, by giving you the best training possible. All right, so that's issue number one. Issue number two is going to be, all right, if you decide, okay, you're going to stay in your country and you have like post-intern or pre-intern exams, if you have trained with the USMLE system, you're not going to fail any of those exams. So every other exam, we believe, pretty much is going to be a subset of the knowledge that's being tested by USMLE, right? So again, just by pure selfish reasons, if you want to do well in Kenyatta, you want to do well in Kampala, you want to do well in Muhimbili, if you are preparing for USMLE, you should be able to crack any of those exams that they're giving you in whatever medical school that you are attending. So that's that, right? So it's paying dividends anyway, wherever the hell you are. All right. Now, so the other piece, which is just economic, right? So when you come here in the United States, the people who matched for residency yesterday, they just got a job, right? You just heard like a ton of people being fired by current federal government. The people who matched yesterday just guaranteed their salary for the next 5 years, right? That salary is paid to you by the US government through basically the Medicare system, right? So you are guaranteed nobody's going to fire like medical doctors, because basically the whole system is going to collapse. As I said, the medical system really depends on us basically serving patients. So part of it is the government is paying us to basically get trained, but also take care of a huge part of the population in the United States. 50 to 60% of medical care in the United States is basically provided by the federal government through the Medicare system. The Medicare system provides medical care for everybody age 65 and older. Obviously, we're an older population in the United States, so a huge part of the population depends on these kind of programs, right? So it's an essential part of the US system. And again, from an economic sense, many of you, if you decide to do extra training in Tanzania, Kenya, Uganda, you probably have to pay fees. If you're not paying fees, probably your hospital has to pay fees for you to basically go to that MED program, right? So if you come to the US, basically you're gonna receive a salary. So you're getting paid to get your training. Okay. I mentioned this, right? You get exposure to highly specialized training. And once you have that training, the other mission is to help you guys transfer those skills home. Again, that's like a very another topic in and of safe. That's one of my own passions, is to make sure that we're transferring those skills back home by supporting training programs in country. For example, we have specialized trainings for radiology in Tanzania, interventional radiology, neuroradiology, and women's imaging, and also we're supporting interventional radiology program in Uganda at Makerere Mulago Hospital. So again, once you have the skills, then you can have the option of transferring those skills and using those skills wherever the hell you feel like you want to use those skills. But again, you can't transfer when you don't have. So I am hoping that I'm speaking to medical students who somewhere down the line in 10 years or so, let's say year 2035, you'll be in a position where you have some skills that we can now begin to recruit you to actually provide care within our home settings and so forth. So that's another long-term mission. Again, I don't care where you end up practicing. If you're a great doctor, we're going to be able to leverage you. It doesn't mean come to the US and move back to Kenya. You can be whatever the hell you are, but I can just borrow you for a week or two. And basically, if we collect a week or two off of 500 people, that's a lot of weeks, and we can do a lot of really good work with that. So, don't get into the whole thing of brain drain and all of that. Basically, we can do brain circulation. You can do whatever you want. We don't complain when people go to Europe and play soccer. People go to Europe and play whatever. But, whenever a medical person comes from Kenya or Tanzania, there's a lot of noise around that. Use your skill, whatever the hell you want to use your skill. And that's a whole nother topic around that, right? So again, it's brain circulation. If you have the best training, then we have the option of recruiting you to work whatever the hell we want to recruit you. And I think it's important for you to be recruited and so forth. But you will see many of our colleagues that we're going to show you in a few seconds, they have now transitioned to other like super specialties. So they didn't stop just as residents in internal medicine. They've gone on to cardiology, beyond cardiology, they've gone to electrophysiology. Some people have gone internal medicine to neurology. Now they've gone to like interventional neuroradiology. So, once you kind of get in and the bug bites you, you may just keep going because you really want to like achieve the best level of like expertise that you can be. And that's not very easy to attain elsewhere outside the United States. All right. So again, as I said, the US is not the only destination, but once you have solid training, then you can go work whatever the hell you want to work and for whatever reason. So you may say, you know what, I want to train in the US and go work in Australia, New Zealand, Canada, Kenya, Tanzania, whatever. You can pretty much, with those credentials, you can apply them anywhere you want, and you can apply them however you want. You may say, I want to work 6 months in the US, work 6 months in Kenya. You want to work, you can do whatever you help. But the first thing is you have to have the skill. If you don't have the skill, then that's really like a mute point for you. We can't really, you're not even in the running, so we can't even have that discussion. So here, a couple of folks, I'm gonna probably butcher some of these names because I don't really have it in like note form, but this Yagape Urasa, I think he was working in India, is originally from Tanzania, and he just matched. So he's one of the people who was just celebrating yesterday and found where he's going. I think he's going to a program somewhere in the New York area, right? So a guy from Tanzania, recent graduate, and basically now is gonna be doing his residency training in the US, all right? Here's, I think, Dr. Samakula. He is from Uganda. I believe he trained at Makerere, and now he's a pediatric resident out in Texas, Driscoll Children's Hospital. Right here is Moza. She matched last year, and she's doing her residency up where somewhere in California. Again, went through our program here with Dr. Kola, and I'm very, very proud of her. And all of these folks have come back and given back to our session. Next here, we have Mabusi, and he also trained in Tanzania and then basically went to Cuba for his medical education. And basically now he's also doing his residency training in the US. Here's another doctor. He's from Kenya. I don't want to butcher his name, but he's a PGY2 at Griffin Hospital. Griffin Hospital is the hospital that Dr. Kola works at, and he's the program director. This is Hesbon Magacha, also has a connection to Cuba, and now he's doing his residency training, I believe, in Tenet. Folks entering, if you can enter mute, that would really, really help me. And here is Piri Mary Kamenju, who also trained at Muimbili, and now is at St. Vincent's Hospital in Massachusetts, PGY2, probably right, no, PGY3, I guess, almost graduating and now looking for jobs after graduation, right? And then who else do we have here? And here is Barbara Dieng, who's also at Griffin Hospital, who's finishing her preventive medicine program, which is a 4-year program with an MPH at Yale School of Medicine, also connected to Griffin, where Dr. Ignas Kola is the program director. Here's Amir Mbonde, again, who did neurology, and then went to basically at Massachusetts General Hospital, Harvard Medical School, to do his additional training, and now has went back to, I believe, Nevada, where he's doing basically a neurointerventional radiology training after neurocritical care. You've done some publications, again, addressing the need for neurocritical care and resource limited settings. Here, Israel Kasago, who's a very super specialized dermatopathologist. I mean, he's done like a ton of, right? Look at these fellowships: dermatopathology, molecular genetics, oncologic molecular fellowship, right? So he did like 3 fellowships after his residency training program. So super, like, specialized person. And this is what I'm saying, like, once you can in here and you kind of understand the training that you're getting, you can basically use that to basically get additional training and so forth. And again, it's just kind of crazy because, Israel Kasago was introduced to me like several years back. now almost more than 10 years ago. When he came, I was an attending up in Connecticut, and he just, hey, I just want to do an observership in pathology. And he came to our, medical school, and we're able to kind of get him like a 6-week observership. And from there, he got like a letter of recommendation. From there, was able to apply for residency. From there, he matched like residency, and the guy's just been kind of going on, and now is basically practicing somewhere in Michigan, right? And who else, right? And this is Dr. Israel with Dr. Kola, and this is Adrian, Dr. Kola's son. You can see how the youngsters are basically shooting up and getting taller than his dad, right? So this is, again, hopefully we have shown you enough to explain why this is worth your time. And then now I'm going to spend the balance of the time just kind of talking about, a little bit of like the nuts and bolts, right? So again, my job here is not to convince you to come and do training in the US, right? So that's not my job. Just for you to figure it out. Is that something you would like to do? Don't do it because Frank Minja says it's a good idea. It's for you to decide whether it's a great idea. And if you decide it's a great idea, then it's my job to make sure you have accurate information regarding that. And we are providing you the best resources. And we're providing that resources very early, so you don't have any excuses. Oh my God, I'm too old, it's too late, and blah, blah, blah. None of those excuses, right? So the idea here is to say, hey, this is the Premier League, right? This is how you get into the Premier League. This is the training you need to do. Now, it's for you to decide whether you want to engage at that level or not. And if you don't want to, that's fine, right? That's fine, right? But this is kind of like, it's not, I just want to make sure that you understand what is my role and how can I help you, right? So please don't ask me, should I apply? That we can give you reasons to, but it's for you to decide, because indeed the training is going to be brutal, right? It's a rough process, meaning it's long, and it will require some personal sacrifice. The same way you're sacrificing right now. You could be enjoying your Saturday, but you're spending some time with your colleagues here, getting some additional exposure and knowledge to the world out there. So graduate medical education, I'm gonna paraphrase very quickly through these slides. All of this information is available, but all I'm doing here is to make sure that we're all at the same level of information. As I said, graduate medical education in the United States is referred to as residency, residency training. Internship is the first year of residency training, so internship is part of residency training. But then after that, once you become PGY2, postgraduate year 2, then now you're referred to as a resident, okay? This is similar equivalent to basically what is referred to as Masters of Medicine in our East Africa programs. Those are the closest things to be, right? So residency in the United States is typically done in an academic hospital, meaning an academic hospital is typically affiliated with a medical school, right? So basically at that point, it has an academic component. And typically the faculty who train you have a dual appointment. So we work for the hospital as attendings, but we also have academic titles. So you see assistant professor, associate professor, full professor, whatever, that is your academic title. So usually when we're working in academic medical centers, I have a double role, right? So I work clinically, because that is what generates revenue, but also I have a responsibility to train the next generation and also do research, and that gives you academic credentials. So basically, wherever I'm sitting here, I'm sitting in two worlds. One world is provide clinical care. The other world is advance the mission of education and research, and that's what gives you the titles of assistant, associate, and full professor, and so forth. So the point is, by having that dual system is how we keep track of your education, right? So basically the medical school is in charge of your education, right? So education is a big component, but the education is provided within these hospitals, and that's why the Medicare basically pays for the clinical service that we provide to those patients, right? Same way the MMed in the East Africa is provided also similarly in a similar combination where, Kenyatta Hospital is basically connected to the University of Nairobi. Same way Muhas is connected to Muhimbili National Hospital. The same way Mulago is connected to Makerere University. Okay. Now, there's COSEXA, which is a different sort of pathway, it's worth kind of, looking into. That is not the traditional pathway of doing, but it's another way in which people can get graduate medical education that is besides the MMed, and that's another pathway, especially for surgeons, where you can kind of get attached into another sort of like an academic setting and so forth. So you can go in, find cosexa.org, and you may know some of your colleagues or attendings who have gone through this particular system. Now, if indeed you're interested in engaging in graduate medical education, you have to pass what's called United States Medical Licensing Examination, aka USMLE. Okay, so the USMLE is a medical licensing examination. So in order for you to practice, even as a trainee in the United States, you must pass a medical licensing examination. Okay, so you're not gonna come as, oh, I train in Kenyatta, or I train in Mulago, or I train in Muimbili, I'm gonna come and like take care of like United States patients. No, in order for you to practice, you're gonna have a temporary license. In order for you to be allowed, remember, medicine is a regulated profession, right? So on behalf of the public, there are regulatory agencies that make sure people just don't wake up the next morning and say, oh, I'm gonna be a doctor because I feel like being a doctor, right? It's a regulated profession. So in order for you to practice, even train, you must pass these exams. So there's a whole rigmarole of these exams. There are 3 exams, step 1, 2, and 3. And those basically, in order to do that, you must go to an accredited medical school. An accredited medical school will be listed in this directory, right? The wdoms.org. You should go in and like search, right? So we went to search for the last time. We kind of searched for this for Tanzania, right? Tanzania United Republic. We found like 11 medical schools that are sort of listed in here. So if you are going to a medical school somewhere and it's not listed in this directory, then it is your job to basically do the paperwork necessary to make sure your medical school is listed. Because if your medical school is not listed, then you cannot even begin this process, because we do not recognize whatever medical school that you have been to. So go in and search. I guess we search for Rwanda. There are like 3 medical schools that are listed there. You can put in your country and kind of figure it out, right? So World Directory of Medical Schools, right? So go in. We went for Kenya. Kenya also had like 11 medical schools, and you go figure out whether your school is listed there, and so forth. Uganda, I guess, at 9. Okay. Now, once you're done with the exams, right? So then you're basically gonna go through the ERAS match. The ERAS match is the last step. The ERAS match is the last step, and that is what we were celebrating yesterday, March 21st. Is the culmination of all of this process. Now you basically put in, hey, I really want to go to program X, and program X says, hey, we really want to have candidate Y, and basically the computer algorithm goes through a matching process of so forth. It's kind of like you're checking out the program is checking you out, and kind of say, hey, they're gonna come and have like a list of, let's say we have 50 candidates, they're gonna rank those candidates. So we have something called a rank list. So I'm gonna have a rank list. All candidates who came to interview at Emory, we're gonna rank them 1 to 50, right? So who's candidate number 1? Who's the candidate we want the most, all the way to the candidate we want the least? And you are gonna say, hey, I interviewed at 15 programs, and I'm gonna rank those programs, program 1 through 15. If I had my best choice, which program do I want to go to? And basically, you're gonna basically list that, and the computer program then goes and matches and kind of basically optimizes and uses the best program you want and the best program that wants you, and basically those things kind of go and get matched together, right? Because basically it's a match thing, because there are many other factors beside medical education that may decide where you want to go. You may want to go to a program for family reasons, for geography reasons, for specialty reasons, whatever it is. Hey, I want like warm places. I want to go to the north. I want to go to like whatever. Remember, United States is 50 countries in one. The United States of America. So there are 50 countries that you could basically go train into within the United States. And each country, aka state, has its own medical regulatory board that regulates the medical practice in that particular state. So not only do you get licensed to work in the United States, but then the state has to say, you can work in our state, right? So Georgia will have its own laws, Iowa will have its own laws, Indiana will have its own laws, Massachusetts, you go. Basically, that's a whole part of the regulatory environment in which all of us work in as we try to serve the public, right? So that's a whole nother thing. By the time you get to the NRMP and ERAS, like you're like, way out there, right? Now you're putting your hat in the ring. And this happens basically the process opens, right? This process whole thing opens sometime in August, September, where the program is going to open the application, and now you submit your application. But this is way after you have your step 1, 2, and 3 completed, and letters of recommendation, blah blah blah, and now you basically submit it in there. The program invites you for interview, and then after the interviews, they're gonna rank their programs, and now you'll be eligible for the match. And yesterday was the culmination of that cycle. So every year, without fail, we go through this process, and every year on July 1st, we have the fresh crop of interns who basically begin their journey in graduate medical education. So that's the rhythm, right? So it's important for you to know this rhythm. This rhythm is pretty much like the sun. It pretty much goes that way. So every year, June 30th, we graduate people. On July 1st, fresh people join in. That's how the machine gets fed, right? So basically, we have fresh people coming in, we have fresh people graduating, and at the same time, we have people retiring and so forth. So it's a well-oiled machine. So why do I say this? I say this because it takes about 18 to 24 months to basically get to the point where you can submit an application. Okay, so let me repeat that one more time. For you to join us in graduate medical education, it's a 24-month process, roughly. Minimum 18-month process. Why is it 18 months to 24 months? It takes 6 months to clear each step exam. So 6 months for step 1, 6 months for step 2, 6 months for step 3, and 6 months for observership/interviews and whatever. That's your 24 months right there. So if you want to come and work with us starting July 2026, okay, that means you should have started your step 1, right? That should have started your step 1 somewhere in 2024. Okay, somebody is asking me, can you share the PowerPoint after the meeting? Yeah, sure, we'll send it via email, right? So that's going to be shared via email. You can have that. I'll ask Dr. Ignas, not a problem, right? Good. Okay, so that's that. So that's an important point because some people forget about timeline, right? And then they'll want to just like wake up and be like, oh, I was so excited. I was on Twitter. So like, March 2025, I want to come to the US in 2026. I'm like, dude, if you decide today that you would want to come and train in the United States and you have not done anything, you don't even have a USMLE number, the first time you can come to train with us is going to be July 2027. Okay, not a big deal. Time flies, right? That time is going to go like that, right? So today, we're at the end of March. We just started this year, right? Trump just came into power. That's how fast time flies, right? It's been almost like 3 months. So 18 months is like nothing, right? It's really nothing. But the point is, in those 18 to 24 months, you have to be doing certain steps. You can't just like kind of cruise control and get into these programs. So the application starts with the USMLE number, and the application also starts with passing the USMLE exams. Okay, so that's so first things first. So understand that timeline, right? So when you're kind of in this zone, we don't want you to be just sort of like floating around and hoping stuff is gonna just happen. It ain't gonna just happen, right? You have to apply. And 2, you're competing against the world, right? It's not, we don't care. We don't care if you train in China, you train in Iran, you train in Israel, you train in Pakistan, you train in Italy, you train in Canada. We don't care. You come into like our list, we're basically going to evaluate you vis-a-vis whatever other candidate that's basically applying to our program. So you have to be competitive, right? And the best way to be competitive, because we don't really know what all the different medical schools are teaching or not teaching, but we know how you performed on our exam. Okay, so it's a nice level setting process, right? So this is what makes the process reasonably fair, right? So because, oh, my blah, I'm like poor, I went to this medical school in whatever, in the middle of nowhere, blah. That's fine, no problem. Here's an exam that you can study and show us whether you can pass. Okay, I feel that's one of the most fair ways in which we can sort of like judge people. So really, the USMLE exam is a very important exam, and also it's a very important process. So the first process starts with getting your USMLE number. Blah blah blah. I won't belabor the point. Okay, again, the system is read by computers. So Mohammed with double M is different from Mohammed with a single M. Is different from Mohammedi with an I, or Muhammad with A's. Those are 4 different names. So if you are from Tanzania or elsewhere and you love to mix names, like you're just gonna do stuff like back and forth. Today you're John Casey, then you're Casey John, you're Casey with an I, you're Casey with a Y. Those are 4 different people. So if you're going to apply for the USMLE number, please decide what is your name. And that name should match whatever's in your passport to the last alphabet, okay? Very, very important. The computer basically will spit you out if you have anything changed in that, right? The order of your names. Ahmed Aden is a different name from Aden Ahmed, right? Those are different names. So you may say like Kinyumbani, whatever in your home, you guys like mix stuff around. Do not mess around. This is basically a very regulated system. So we want to minimize fraud. So we want to minimize people pretending to be who they're not, right? So in our systems, unfortunately, people are trying to get away with these things and use all types of different names. But at a minimum, you should have 3 names, and those 3 names should match the passport, because you will not be able to advance in this process if your name alone will basically kick you out. So one of the advice that we really give people is get a passport or a national ID, because that's not something you can change every day, okay? So get that, and whatever's in that ID is what you should use on your USMLE application. So end of that, right? So, once you have all of that, you basically go in and basically register for a USMLE number, okay? Now, the great news is you can register for USMLE number for free. No money. You can do it today. It's free, right? And once you have that number remains for you. The only caveat here would be, if you haven't really decided what is your actual name, maybe get a passport first before you register for USMLE number, because the USMLE number is a single number for a single individual. And if you end up like changing your name, then you unfortunately will have to go through the process of basically legally pulling all affidavits and whatever lawyer process to change that name and so forth. So it's a bit of like a process. So go in if you're you're happy with your name, and or you have a passport and already you've gone through that process. Go in, register for your USMLE number. That is great, right? So go in and get a number, right? So again, do not try to like trick the system, and please make sure you're not gonna be able to do this process twice. And the system again is pretty robust. So you can't really trick these systems, guys. They've been doing this game for more than 100 years. So they know all the tricks, and they've seen all types of fraud from all different parts of the world. So they know this game like code. So we know when people are sort of gaming the system. We may not know exactly how you're gaming the system, but sooner or later we'll catch up with you. So do yourself a favor and just stick to the rules. No big deal. So go in there. We said that never ever try to create another one. Changing the numbers is like like the names and whatnot is kind of a pain. So just get your name situation fixed, and then basically get your USMLE number. It's free. We kind of talked about that and whatnot. Now, I will say, if you do not, and I see Dr. Kola joining in, if you don't get your number in the next like whatever week or month, it's highly unlikely you're going to basically continue with this process, right? Because if the first step is free, and that alone is kind of like giving you trouble, probably you don't really have what it takes to kind of like do this process. The same way, I gave this link and I made sure that you have to register to become part of this thing, and it's gonna put the Zoom link all the way to your. It's gonna put the Zoom link to your email, and if you can't even follow that simple instruction, then probably this process is not really for you, because then you need a lot of like help basically. Because say, hey, go register for this number, is free, and that needs a lot of like brain power to process. Then probably you can just tune off and just kind of enjoy the rest of your weekend, because basically everything from here is gonna be a lot harder, right? So that's the issue. Like, if the most simple step is difficult, then everything else is basically going to be like super, super difficult. It's kind of like, hey, you want to like train for the Premier League, and I say, hey, you got to like run around the field like 2 times, and that alone is difficult for you. Then basically you've already decided for yourself that this is not really where you want to be. And that's totally fine. I don't want to take it personally. This is for people who want to do it, right? This is not for me to kind of, hey, really, I'm not begging anybody to do this. We have enough applicants that we have, then we can select, right? For any position that we have open. So Emory has, I don't know, Emory Radiology has something like, I think like 18 or 20 radiology residency spots. We receive anywhere from 10 to 15 applicants per spot. For every spot, we have 10 to 15 applicants. So there is no shortage of applicants. So we're not really trying to drum up more applicants who are not really sure whether they want to do this process. But if you are serious, then basically you can continue to listen. We can kind of like, engage more. So we kind of talked about that. And then there's going to be like, document verification. The reason we want to kind of like, get through the document verification is this is best done while you're still a medical student, okay? Your dean, all right? Your dean will have to verify that you are indeed a medical student at that medical school. Now, once you graduate, it can be difficult to engage with your school. Let's say you get posted to your internship far away. Let's say you get posted to Mbeya, but you graduate from like Muhas and so forth and whatnot. So that's going to be a minute, for you to kind of communicate with Muhas to get them to verify your documents. So that's why when you're MD1, right, Dr. Kola, you can help me answer those questions in the chat as we go along, and then you can kind of rewrap and emphasize them as we kind of keep going. So again, if you're MD1, right, you verify that your medical school is in the directory. Now you can, and you have a USMLE number, then you can have your dean verify that you're indeed a medical a medical student at that school and so forth. So the document verification takes time. What does it mean by takes time? It can take anywhere from 12 to 24 months. That's 2 years, right? Just going through the process. Remind the dean, oh, I forgot, blah, blah, blah. I didn't see that email. Oh, I gotta send him like another email. Oh, that thing got lost, like what? It just takes time, right? So we want these processes to go in parallel, right? You can walk and chew gum at the same time. You can be studying for USMLE and your dean can be processing your document verification. You can do step A and B in parallel. It doesn't have to be, I finish A, and then I do B, and then do C. You can move things in parallel at the same time, right? So that's the whole point of it. So even as you're becoming MD 2, 3, 4, you can be studying for USMLE exams. And that to me is the best case scenario. So what we want to do here is turbocharge your current medical education. Right, so that's the whole thing. So you're applying for USMLE exams, you're using your USMLE first aid to study, and you're becoming a great medical student. And at the same time, your dean is actually helping you with document verification and blah blah. So here it says give yourself like 6 months to complete the process, but knowing our country, 6 months could be 12 months. Very, very easy, right? So you got to do document verification. It's not free, $160. Again, it costs money to get money. So, you do have to invest in yourself. $160 if you go to medical school. Yeah, it can be a lot of money, but in the grand scheme of things, it's not that much money and it's well worth the investment. So once you have the document verification, they're valid for 7 years, and 7 years is more than enough time for you to basically achieve admission into a graduate medical education program. Remember, I was aiming for 18 to 24 months, right? The USMLE people give you 7 years. All right, like 7 years from when you basically started the USMLE 1 process. You have 7 years to basically clear that process and so forth. So, get started. And again, I really believe in parallel processing. Things that you do should sort of help each other as you kind of go along, as you kind of like, go along, right? So, all right, so important, all right, so you don't want to be ready for exam before those things. So again, okay, a little bit about USMLE, right? So I don't want to wait, right? It tests everything, right? So this is basically the exam that you have to take before you can enter the clinics and touch patients, okay? So this is called the preclinical exam, right? So in the United States, roughly, you have to do 2 years of medical school, anywhere 18 to 24 months, of basic sciences, anatomy, physiology, biochem, pharmacology, pathology, parasitology, micro, epi, biostat, whatever, all the basic sort of sciences before you can go and touch patients, okay? So the USMLE exam here, it's basically allows you to now enter the clinic and begin to actually interview and interact with live patients, right? Remember, this is a licensing exam. So if you don't pass the basic sciences, You're not allowed to go touch like patients. Like, what the hell are you doing like touching patients when you don't have any sort of basic, so like, fundamental knowledge? Currently, the exam is pass fail. There's a lot of talk about maybe bringing it back and having it be like a scored exam. That's this TBD. It's not for me to decide, but it used to be a really great way for students, especially who train outside the United States, to distinguish themselves, right? So if you really crush this exam, that really shows they have very good fundamental training. Okay, so also step 1 helps you to prepare for step 2. Remember, these exams build on each other. So if you have a good foundation at step 1, chances are that's going to help you as you're basically preparing for step 2 exam, right? Again, so now a little bit about when to take step 1 if you are not training in the United States. Now, education in the United States is very integrated, right? So meaning even in the basic year 1 and 2 of medical school in the United States, a lot of the basic science are sort of like well sort of integrated. But in our curriculum, at least I can say from Wimbledon and so forth, it's not as well integrated. So meaning a lot of this sort of like second level questions, and I think that we may have a question in here that are sort of like implied knowledge is not as easy for you to pick up if you're really gonna do. Let's say, an MD2 student in the United States is ready for step 1. MD2 student at Mwimbili is not ready for step 1, right? So probably you need to be MD4 or MD5 to really do well in step 1. So usually we kind of say, don't rush into it. You got time. So usually the way I kind of say is like, hey, if you're in Tanzania, Uganda, Kenya, you got 4 years to study for step 1. Okay, where in the United States, you got to take that exam or you're not going to advance to like MD3, right? So here, you don't have a choice. It can be like a message, oh, you know what? I'm going to wait until like MD4 and then take my step 1. No, you have to pass basically step 1 before you basically go to basically year 3, MD3 here. So, but again, we do a lot of work here to integrate our medical education. Step 2 is gonna get into like more clinical stuff, internal med, ped, surgery, OB-GYN, epi, and so forth, predominantly internal medicine, 56%. But again, these are 3rd degree level knowledge, right? There's nothing like what is penicillin, right? There's nothing kind of like that sort of like, straightforward, like what is. It's gonna be sort of an implied sort of question. I think Dr. Kohler had a really good example there of like a sickle cell case that was very, very sort of like, very sort of like 3rd level knowledge, right? So you got to do step 1 and 2 to get to be ECFMG certified, but also you want to do step 3 if you can, because again, step 2 and 3 are scored, right? So that's also a way for you to kind of distinguish yourself and show that you have a high level of knowledge. Usually we're aiming somewhere around 240 and above. So if you're getting like 240, 245, 250, that's a solid number that you want to aim for. Anything less than 240, it's probably like a little bit weak and whatnot. Like anything under 200 or 210 is kind of like pretty damn weak. So I think we want to kind of be competitive. And again, if you've been studying all along, if it's taking the US medical students 6 months to study for this exam, surely if you're studying for 4 years, you should be able to do a lot better. Essentially, you have to beat the US median, right? The US median is sort of like the middle score of US medical students. You should be able to kind of beat that because you have a lot more time to kind of like prepare for the exams and so forth, right? So you get that, you go through the process, get the ECFMG certification. As we said, right, reading books is not going to cut it. You want to have a lot of that material sort of in there, right? So here is the Bible, okay? Or here is the Quran, or here's the Torah, whatever religious book that you sort of subscribe to. For US graduate medical education, this is our Bible, okay? So you need to buy this book, invest in yourself, buy this book. If I had a lot of money like Bill Gates or whatever, I would buy this book for every medical student on the continent. Literally, I would force this. When you're like showing up to my medical school in Tanzania or whatever, each one of you would get this book. And basically, I'll be like, please commit this book to memory, right? That's your job for the next like 3 to 4 years, right? So again, in Tanzania, the first 3 years, I guess, are basic science. And then you get like 2 years of a clinical and then a year of internship. You have 3 years to crack this book, right? So you have 3 years to basically understand this book front, left, and center, right? There's nothing in this book that should be surprising, right? So this to me is really where we should be level setting. And that's why I feel like if we begin to make sure everybody has the same base of knowledge, then we can begin to raise the level of subspecialty training. But if your basic knowledge is like weak, then we cannot do like neuroradiology and all the other things, because all the sort of like basic stuff is like weak. So we want to make sure you come in, all you guys are coming with a solid foundation. Okay. So next steps, so basically our cadence is typically, we do this particular talk, USMLE 101, sometime in October or November or something along those lines. And then in February, we just had another one, which was more USMLE 201, that was really geared to the people who are now ready. Now, these guys are ready to go in and actually do the exam, right? So this is a kind of overview. And then sometime in May, we're going to basically deal with people who actually apply. So these are people who 3 months from May 2025, right? 2025, they're gonna be putting in the application sometime in, let's say, like, August, September, like whatever. So it's gonna be like, tell you like, once hopefully at this time you've cleared all your steps 1, 2, and 3. You got your letters, you got your observers. So now it's how do we polish your application. But man, if you have like crappy scores, step 1, let's say like you fail step 1, you like step 2 is kind of like barely there, step 3 is barely there. There's nothing we can do, right? So if you're not competitive, there's nothing we can do to kind of help you. So, do yourself a favor to be competitive, because basically, again, you're not going to be interviewing with me. You're not interviewing Frank Minch. You're not interviewing James Cole. You're interviewing my colleagues. And my colleagues obviously are going to select the most competitive candidate. The same way you would want them to do that, right? So if you're leading one of these programs, oh, here's my buddy from Tanzania. He has a step score of like 201. I'm going to take him because his mom knows my mom or whatever. No. It doesn't work that way. There are panels, right? You cannot go through a panel if you're weak, right? The panel doesn't really care. The panel is anonymous. So you're going to get interviewed by 4 or 5 people. They don't know you. And then you're going to get discussed by a panel of like another like 10, 12 people. Nobody knows you. All we know is your record. So please make sure your record speaks for you. So that's what's going to help you. And, we kind of get into that. So, if indeed some of this stuff sounds exciting and you really want to kind of engage in this space, here's how we engage, right? We don't do WhatsApp groups. I don't do Telegram groups. I rarely sort of engage one-on-one on like social media and whatnot. Send an email, okay, with your USMLE number to usmlepursuit@gmail.com. Okay, we deal with cohorts. So depending on how you are progressing in the system, we will address you. So when you pass step 1, you will move to the step 2 group. When you pass step 2, you will move to the step 3 group. Okay? It's not because I like you. It's not because you're my friend. It's because you have demonstrated sort of like something, right? So in order for us to engage with you, you need to have a USMLE number. If you don't have a USMLE number, there's nothing for me to talk to you about, right? So it's like, you do you and I'm going to do me. When you pass step 1, right, then we can sort of like engage. So I'm not going to talk to you about step 2 when you haven't passed step 1. I'm not going to talk to you about step 3 when you have passed step 1. We're not going to talk to you about, hey, how do you become a better, position yourself for the match residency and you haven't passed your USMLE exams. Like, you're wasting my time and you're wasting everybody's time. And that's the one thing that unfortunately we haven't figured out how I can buy more of, right? So I cannot buy more time, right? If I can do that, then basically I'll be able to kind of waste it. But I don't like to kind of waste people's time. So we have learned the hard way. People coming inbox want attention. You talk to them for hours and hours and hours. And then you ask them in 3 months, hey, do you have a USMLE number? Oh, no, I'm still thinking about it. Shit, you just wasted like 2 hours of my life and you had no intention of going through. So please self-select, right? If you are not ready, just figure it out, figure out your head, when you're ready. And then when you're ready, then we're going to engage. So we're not going to engage with you until you're sort of ready. So you can see we work with cohorts and we have checkpoints, right? So they're very simple checkpoints. Hey, do you have a USMLE number? Okay, now you enter the cohort. Have you passed step 1? Now you move to the next group. Have you passed step 2? Now you move to the next group. Past step 3, now you move to the next group. And now we can really invest our personal resources to kind of really help you. But we're not going to do this like social thing where you just want to like chat along. You want to kind of like, do some like random social media engagement and this and that. There are plenty of groups for you to do that. You don't need to kind of like, be with us to kind of do that. So if you like to socialize with your buddies, you're welcome to do that. But I don't feel that that's very effective use of our time, right? So we want to give you accurate information. We also want to make sure that you're focused. And many times in those WhatsApp groups, very quickly they become distraction groups. Like people, oh, hey, I want to just like, feel that I want to be like the joker, the comedian of the group and blah, blah, blah. No, we want you to kind of be focused. There are many places where you can get entertainment. I don't need to be the one sort of providing that and so forth. So again, we're in the business of making better doctors. I'm not in the business of sort of entertaining you and so forth. There's many places for you to kind of get that and whatnot. So I hope you will not take this the wrong way. We're fairly direct, and I want to respect your time, but I also need you to kind of respect our time as well. So, okay, so what other things can you do while you're still a medical student, right? So if you have an opportunity to come to the United States for an elective, right? So let's say, hey, you know what, you're in the summer, you're able to come and do, explore, right? Basically exposure, right? So one of the things with my Tanzanian colleagues, I'm always very cognizant of is the lack of exposure, right? We don't know what we don't know, okay? So please do not stay in a little cocoon somewhere at Muimbili, Kampala, Nairobi, in your little room. You need to kind of get exposed. Please come and seek information, right? Seek information. So how do you do that? Seek opportunities to go abroad, seek opportunities to go to conferences, right? When we have a lot of volunteers we send to Tanzania, Kenya, Uganda, where talk to them. Hey, how is it going to medical school in the US and blah, blah, blah. Are there any, like engage with them, like sincerely want to like learn from them, right? Try to learn, like, hey, how is this done? How do you guys do it over there, right? Expose your brain, right? Exposure is very, very important in this process, because exposure is going to help you to understand what is possible, right? Many times you're going to have a lot of like information that's not accurate is because people are not exposed. So really a big part of your education, besides passing the exam, is to sort of understand what is possible out there, like what is possible. So when you go on social media, use it judiciously. Follow people you feel are adding value, right? Don't just follow some like random accounts. Yeah, it's fine to be entertained and all of that. In my own life, I play a little bit more on Twitter, maybe a little bit on LinkedIn, but Instagram and all of that to me is like pure sort of entertainment. But maybe people are using it for education, but I don't think the education content is as high as on Twitter and maybe sort of like LinkedIn and whatnot. No offense to TikTok, no offense to Snapchat, no offense to all of that. But my point is, you got 24 hours, whether in Kenya, whether in the United States. How you use those 24 hours is up to you. I can't make one more second in a minute. Right? So we have limited time. So please set aside time where you actually are able to control that time and use that time to kind of invest in yourself. So exposure is a great use of time, right? So if you go to a conference, that is a huge investment in yourself. If you go and spend a time with like somebody visiting in your country and so forth, and you really spend an hour or two really kind of connecting with them, that's a good investment of time, right? You can scroll all you want on social media, but actually connecting with another human being is really the best use of your time, because that's really going to elevate you and really give you that sort of exposure and whatnot. So really, 100%. Collaborations are really important. And those are ways in which, well, let's say, for example, you connect with a medical student who's coming over for rotation in Kenya, Tanzania, Uganda, and whatnot. And let's say you have an opportunity to come over for an elective. And so they're going to be a host on that side, right? So if they're in Dar es Salaam, please goddamn host them, right? Take them to like Wavuvi, take them to Samaki, take them somewhere, just host them. And when you come over here, then they're going to host you. And that's how the world works, right? It works on human connection. It's not going to work based on like blah, blah, blah. My name is so and so. It's like, hey, did you make a human connection? Hey, I'm a mother like you. Hey, I'm a sister like you. Hey, I'm like this like you. Hey, I'm also fasting right now. Oh, I'm also observing right now. Like what? Find a way to make a human connection, because at the end of the day, we are trying to take care of humans. or patients, right? So making human connections is really part of our job, because the only way for you to convince somebody to take really poisonous medication is for you to make that human connection, right? So this is a constant job that we're going to be doing for the rest of our lives, is connecting with other humans, so that way we can help them with the little knowledge that we have and so forth. So likewise, you want to connect with colleagues and so forth, and really that is what makes our job fun, right? So the reason we stay in academia, I get to work some really amazing colleagues, and I also get to work some really amazing like trainees. So these are trainees who came, I don't really remember the names, but they came to Connecticut, and here's Dr. Kola at Griffin Hospital, like hosting them. And so they got a chance to basically through the MUHAS program, whatever, they get to spend like at least I think like however, like, I don't know, several weeks in the United States, I believe at Dartmouth, kind of like observing that, so forth. And also there's a lot of like push right now to basically have like basic bi-directional exchanges. So therefore we don't just send US students to the Africa and so forth. We actually have students from the continent come and kind of get exposed. So this, while you're in medical school, is a really great opportunity for you to do. So obviously, took them like to the medical school there at Yale and Harvey Cushing. This is the Cushing of Cushing's disease, right? This is the Harvey Cushing who actually kind of did resection for like pituitary macroadenomas and so forth. Down in this library, they actually have a whole museum like built like around them, where it kind of saved all those like brains from like old school and whatnot. So history is like a big part of it. I don't want to waste your time, but I'm a big like buff of history, because I like to know how a thing sort of connects us. So here we are in 2025. I want to know, what was it like 100 years ago? What were people kind of thinking of whatnot? Because those people are just like us. They're human beings just like us. So it's now our time to kind of like build out the future. So I think I've kind of concluded that talk. I will switch off now. Dr. Kola, if you may please come on and help me out here with any, maybe you can say hello to the group, and then basically we can go into a Q&A session for the rest of the hour. So karibu Dr. Kola, and I shall, yeah, so karibu Dr. Kola.
Well, thank you. Hello, everybody. Good afternoon. Good morning, who are on this part of the world. Can you hear me?
Yeah, we hear you well. Perfect.
Excellent, excellent. Thank you very much. My name is James Ignace Kula. Thank you, Frank. Frank is an early bird. I saw him at 6 a.m. I'm not gonna make it today. So it's 7 or 9 here. So I kind of found him somewhere like around 6:40 and listened in the background. So I'm originally from Tanzania, born and raised from Moshi. I studied at Old Moshi Secondary School, and then I went to Iliboru for high school, and then Muhimbili. So I completed my medical school there, worked in Kenya a little bit for almost like 2.5 years, and came to the US to do my MPH. Did my exams and transitioned into medicine. So I'm board certified in both internal medicine and preventive medicine, and I'm an associate program director for the internal medicine preventive medicine residency program at Griffin Hospital in Derby, Connecticut. So I teach residents, I recruit them, I work with them, I try to empower them, and we have been trying to kind of reach people, and we have been doing it anecdotal without any kind of systematic approach. And if Frank approached me, I say, James, the only people we can see are the people who knows me or know you or know somebody who knows you. And we have to find a way to reach the unreachable, to reach the people who don't know any of us. And that's the essence of this. And at Frank, I'm real thankful that he showed up at that time, because what was happening is I was not in, I'll pick people, I'll talk to them, exact talk which Frank has given, I'll give somebody over the phone, over WhatsApp, spend almost 90 minutes, 2 hours talking to them, giving them different leads. Not as organized, because it's I'm doing one-on-one, and it will change every time we talk to somebody. And then you tell them, okay, get USMLE number, and a month later you call them, hey, do you have USMLE number? Oh, I'm still looking at some things, sijatulia, kuna vitu naangalia. And then what I learned is those people who don't get USMLE number, like in the first month, 1 year later, 99%, they don't have USMLE number. And that's what, so I was kind of getting burnt out. Then, you become like you are resenting. And I think like there are still good people there who these bad people can make them miss. And so when Frank came with this, we can talk to them like in a group and then follow through. I think it's a good use of our time. I'll give you a statistics. In November, we spoke to 650 people. They registered like you to come for the session. They came like 200 and the rest, they get all the recording. Guess what? From the 650, only 50 people sent USMLE number. Up to now, only 50 people sent USMLE number, And guess what? Another 30 people listened to us from YouTube and sent USMLE number. So I'm looking, actually I'm collecting data. I'm gonna look whereby the YouTube people will override the live people. But don't be a statistics, don't sit on this, get your USMLE number, get situated, get started. Because when you study for USMLE, it makes you a better student. It makes you a better student. You understand more. You can integrate more. You're more confident. You look at a patient. You can throw down your differential diagnosis. You're going to be a better doctor, full stop. Because being a doctor is about knowledge. It's not anything else. What separates you from a clinic officer, from somebody else, from somebody who is practicing like bush medicine is the knowledge, whereby you look at something, somebody will look and see just a rash. You look at it, you diagnose celiac disease. Somebody will look at an image and say, oh, you have a mass. You need to go for colonoscopy. We need to do this. Probably you have cancer, you have anxiety. Guess what? It's interception. But if you have not seen it, you don't know it, you'll give different wrong ideas. So the fact that you're preparing for USMLE, first thing, it makes you a better doctor, you're knowledgeable, you can practice well, and that's it. But it will open for you a lot of opportunities. You can train here, do internal medicine, do cardiology, do electrophysiology, and just deal with electric activity of the heart, and you can transfer this skill back home, whereby now you go like the way Frank is doing. He have started interventional radiology. It used to be you get a kidney, you get a stone in the biliary tree, you get cholangitis, you just die. But now with IR, they can do CT guided, they go there, they pull out the stone, you live to die another day. So that's what we are looking for. Impact back home, impact to support our people, and that's the essence. So, there are people, I've tried to answer questions in the chat. There are other questions you are going beyond, but it's good to explore. But first thing first, let's focus on what you need to do, why you need to do it, and convince yourself. Because when you come and we talk about 201, we really talk about how to prepare. Because real preparing for USMLE is not like reading Kumari and Clark and Robbins for pathology and the Jaweds and go and do it. There's no way you will make it. There are specific way to prepare, and that's the essence of these forums. We show you what to do. We want to find you, tell you, hey, there's this one. You read about it, you're informed, you convince yourself, and then we show you this is the way to walk through and kind of take you through. And this, if you follow it, in 18 months, you're done. So there's no need of worrying. Somebody is asking me after 5 years, it's almost impossible to match. If you know about USMLE or medical student, literally, there's no reason why within 18 months after graduation, you cannot apply for residence. There's no reason, unless you're playing. So you should not worry about being late. This is somebody who has graduated, is now finishing internal medicine residence after he has worked for 3 years. So he's 7 years post-graduation and wondering, man, I'm just knowing now, No, for you as a medical student, and that's why I want to capture you early, you can start preparing, you can do it early, and time is not an issue to you if you are real serious about it. So, it's open, you can kind of
So you got,
unmute.
Asante Dr. Kola, we got to get these folks here to engage a little bit. Okay, so welcome to America, okay? So your first lesson in America is if you stay quiet, we assume you don't know anything, okay? So that's why Americans are loud. So please, for the next 45 minutes, anything in your mind, feel free to either put it in the chat or raise your hand and ask a question and so forth. Basically, again, feel free. This is how we train here in the United States. And I think it's important for you guys to be comfortable and chances are whatever question you have, chances are 10 other people in this group have that exact same question. So I want to give a chance to to Elton Mahulu from TAMSA to just say a few words, because he's been really helping us to coordinate through the Tanzanian Medical Students Association. And we would like to do these efforts a little bit more organized, so it becomes less of a one-on-one kind of effort. So if we are able to collaborate and have the Medical Student Association in Tanzania, Kenya, Uganda, and we can just have like a joint session and whatnot. It's the same information, but we really want to make sure that everybody has exactly the same information, right? It's the same book, it's the same thing, right? We all want to be practicing the same type of medicine. So I don't know, Elton, if you're in a good spot, if you can say a few words on behalf of TAMSA, that would be great. And then anybody else who has questions, you can throw them in the chat and we'll start going over the questions that were raised in the chat. Karibu, Elton, if you want to unmute.
Thank you, Daktari. I hope I'm audible.
Yeah, Karibu, yeah.
Asante. So, first of all, I want to appreciate for your time. I know it's early in the morning there.
Your network is not so great. I don't know, you're kind of breaking up a little.
Your time. We have talked with a colleague from Kenya, Usake, and I appreciate all of you to join this session. But for now, I've seen someone also ask here, if once institution is not registered on board directory of medical school, what ways to do so as you can speed up the process?
Mahulu, I'm looking at the questions and I'll answer them.
Okay.
There are most of the questions before I've put them in the chat, but there are 2 new questions that I will go through. So don't worry about that.
Okay. All right. Sounds good. One question, Elton, while we still have you is, how can we reach more TAMSA members, and how can we make sure every medical student in Tanzania, for example, has this information? Is there any other forum that we can use to reach them, or is this sort of like we've maxed out?
Yes, we can do it. We can do it better because in October we always have General Assembly.
Mm-hmm.
So if we can get time to speak about USMLE,
yeah,
it will reach more people.
Okay, great. All right. So October 2025, there will be a TAMSA General Assembly?
Yes.
Okay. Where is it going to be held?
It is going to be hosted in Dar es Salaam.
All right, sounds good. Please send us the dates and we will see how to participate. All right, great. So let's go. Asante sana, Elton, for your comments. So maybe, Ignace, if you can just go through, just to voice the questions that were in the chat.
Yeah.
Again, these are sort of recurring themes. I know you've answered them. But once you have the USMLE number, is there a time limit since you have that number to take in exams?
There's no time limit. USMLE number is just a starting step, and you cannot do anything unless after you do document verification, because that's what will tell them that you're a physician and you're not a plumber. So as Dr. Minja said, document verification takes some time, but you cannot start document verification before you have USMLE number. So you apply USMLE number, in 5 business days, you get your number, you are listed there. And so you start your document verification, and when it's done, that's when you can now apply for the test and take the exam. So USMLE number is not really a limiting step. It's your document verification. It's you and your dean kind of submitting everything. And for you to be able to do document verification, your school should first be in the well directory of medical schools. If it's not there, then that's a whole different ballgame.
Yeah.
Because it has to be there first. I don't know what the schools do, but it seems it's quite a kind of not really a cumbersome procedure. But once it's there, then your dean or your person, your signatory, which is mostly a dean of School of Medicine, has to be recognized by ECFMG. Now, that is the program which University of Dar es Salaam in Mbeya are trying to do. And it's not uncommon that you are because sometimes there's change of leadership. Dean change, you have a new dean. So the dean which was verified is not in the office. So if it's your time that you are verifying your documents, then you have to contact the ECFMG. They send papers to your dean will sign and attest to everything. It will go back to ECFMG, then will be a recognized signatory, and then he can verify or she can verify your documents. So there can be some few things which can make the process lengthy, and that's why, like Dr. Minja was saying, make sure you start the process early so that whatever hitchbacks you hit, you can kind of modify them and you are not throwing off the rail whereby, and while you are doing this, keep studying because studying takes
One quick question.
Yeah.
So USMLE number, it sounds like a social security number, meaning it's like your identifying number. But there was the 7-year thing. So that's the ECFMG. After document verification, you have 7 years to apply or match. Is that what was the 7-year limit?
Okay. So when you get your USMLE number, which you can get as soon as you join MD1, because you're a medical student, you are tested there, I'm a medical student, you can get your USMLE number. Once you get your USMLE number, then you start document verification, which will finish, of course, completion of document verification is you submitting your graduation degree. But remember, you can take even USMLE step 1 before you graduate. And so, which means your document verification is not really completed. And so but when you finish your document verification, like everything is done, then the document you have verified lasts for 7 years. After 7 years, they expire. And it is the same way. If you took step 1 and then life happened, if it ends 7 years, your step 1 results comes to null, like you have not done it. You drop off the record like you have never attempted USMLE, and you can just start afresh if that's what you're planning to do. So the 7 years is kind of the time which verified document lasts. I don't know why they choose the 7 years, which really makes sense. So even if, let's say you complete verification of your document, kind of your stamp date, let's say, is your second year. It means you'll finish medical school after 5 years, which is 3 years, and have 4 more years that your document is still eligible. So you know from MD2 and you need extra 4 years, you have not finished USMLE, you're in trouble. I mean, like, you're not there. So the time is
so I'm trying to put like a
almost
bit of like a timeline here, assuming we are starting talking to MD1 students. So MD5 may be the best year to do like, you know, step 1, would you say? And then post end of intern year, they would do step 2, and then basically 6 months after that they can do step 3 and maybe sort of apply. Would that be roughly like an ideal? So let's say we're talking like an MD1 student who basically has all options. What would be a good timeline?
For MD1 and MD2, I think the key thing is to continue to prepare, read USMLE specific material as you go through. You know, you read biochemistry, you go to biochemistry in first aid. You read microbiology, you go to microbiology in the first aid. You have like Kaplan notes, you listen to the videos, you kind of consolidate your knowledge. But we don't do integration really. In the first 3 years of medical school in Tanzania, we don't really do like a clinical part. So you go to your 4th year, you do your clinical part. Guess what? You had a very strong knowledge. You have a very strong 4th year. You are looking for elective, just like Brenda Limo, who came. You saw me with him in Griffin. So he came in his 4th year, when in his vacation went in to join the 5th year. And so you do your clinical rotation in 4th year. When you come to 5th year now, you have done your 1 year of clinical rotation and you have really a solid knowledge. I think you should be ready in your 5th year to take your step 1. And then when you do your university exam, you graduate, you have to graduate. That's the most important part. You graduate, and as you're starting your internship, you do your CK. So the key thing is when you are finishing your internship, you are almost ready to put your application in, you know, and that's how you can really connect the dots. That should be the deal, the ideal approach you are looking at, whereby you look forward to just finish your internship and transition into residence, you know. And that's how you can really join. You're young, you just graduated, you're a fresh graduate, you have all the opportunities open for you, because most programs will start filtering people by the time they cross the 3 years threshold. And it's with computer and AI, I just go to my, we get so many applicants. I'll tell you, for Griffin Hospital this year, for our 10 slots, we got 6,000 applications. And so we'll go and filter, because we'll filter and say, you know what, if you have graduated of this year, you have score less than this one and this one, I don't want to see you, and then I'll start seeing the people, within that the group that I want, and those are the people I'm going to look at the applications and do whatever. So it's robust. You need to prepare early. You need to pass well. And when you do those things, you will come through. Your numbers will speak for themselves. So it's really important, the way Dr. Frank was saying, don't think that you'll score just 201, just one above the cutoff, and think, because I know Dr. Kula is going to interview me, I'm not even going to look at your face. I have people who have 250, 260, and believe me, the way you score in your USMLE exams, that's exactly the amount of medical knowledge you have. There's no caveat, I had a bad day, it's like, this is a one-shot thing. This is not my level. I'm so smart. I scored 201, but I'm a 260 kid. You're not. You're not.
Nice. Great stuff. Some questions keep coming in here. So we kind of covered that. I think the timeline question, really, I think we'll have to kind of codify that. I think that's important for people that kind of get lost in the weeds. And again, it's the lost in the weeds because we don't have a culture of parallel processing. So every one of us is like, I'm going to do A, and then I'm going to do B, and then I'm going to do C, instead of doing A, B, and C in parallel at different sort of speeds and so forth. So that's a good point here. There was some confusion regarding externship observership vis-a-vis clinical elective.
So, when you apply, when you're applying for residence, what are we looking at from the program standpoint? I'm looking for you, can you thrive in this environment? Because when I commit and bring you in, I want to see you graduate. Unlike what you are used to see, where people come and they do MED and they are discontinued, for us, when you come and we take you, we do everything to make sure that you graduate. Now, what will show me that you will thrive in this environment? You know what it is, So if somebody has done an elective as a medical student, so they have worked within the US environment, they have touched an electronic medical record, they have real dealt and wrote a note, So that's different from somebody who has not even opened a computer and is coming. So I'm going to tell you, oh, this is how you open a computer, power it on, you need to log in here. So it's like, I can't teach you all the ABC. So the clinical experience, really, what people looks at is you have seen the look-alike of the environment. And when you come on July 1st, because you come on July 1st, you're an intern, I'm expecting you to function as an intern. You evaluate patient, you report to me, we discuss, we go back and forth, we treat, we move along. So the observership, the rotations real attest to that you have tested it. You know what it is. You know what you're applying to. You're not going to come and chicken out, because one of the things that freak out program directors and program leadership is somebody coming and 3 months later, you know what? Radiology is not for me. I cannot read 60 images. It's like, what is this? I'm just seeing shadows. This is the first time I'm looking at X-rays and I'm just seeing shadows. So they want so that's why that's what we look at in the application. As a medical student, you did some extra radiology rotation, you have done some elective, you have written a paper, a case report, you are interested, you know what it is, and kind of that's why you're applying for it, and you will thrive. So we are betting on you that you'll thrive. And
the other thing is, when you come as a clinical elective, right, usually also you then get treated the same way as the medical student in that rotation, right? So this will be almost like a sub-intern, right? Vis-a-vis observers are just kind of like, they're just kind of watching what we're doing. But when you come as a clinical elective properly, you're actually evaluated as another medical student, right? So in some ways, that evaluation can kind of carry a little bit more weight. Though those opportunities are probably a little bit more difficult, and I think most medical schools probably charge you to do a formal clinical elective. Like if you really want to, you basically have to enroll in that sort of quote unquote medical school for that month and so forth. So, you know, all of those are good opportunities. It depends on like what's sort of available to you. And many times when we have our collaborators and volunteers come over to your countries, you may explore those opportunities with them. Hey, you know, are there any like opportunities for me to come and like do a clinical elective or observership at your medical school and so forth? And that can kind of give you an out to kind of like, you know, explore that. But again, it's all about exposure, as Dr. Ignas said. It's like, it's very different if you've seen something before. Hey, I've been part of like a medical rounds, or I've had to present at a department like, you know, rounds and so forth. That experience in and of itself, I had to present at an international meeting. That's gonna cook you in such a way that, hey, you had to go through those steps of like being stressed out, being not really know what you're going, and sort of like, you know, doing like the draft presentations. All of those are parts of training. I think like people, so this will come in because the other part, so USMLE, first aid is great for book knowledge. And then there's a life knowledge, which is like soft skills. How are you punctual? How do you show up? How do you dress up? How do you present? When do you ask a question? How do you ask a question, right? All of those things have to be learned, right? So these are things that are very sort of subtle. And if you've never done it before, you don't even know how to act. You don't even know that there's an opportunity here. And you're just kind of like, you know, sitting there because you've never been exposed, right? So the exposure piece of it, being in a different environment and having to integrate, is an experience in and of itself beyond books, right? It's the same way you walk into a patient's room, you've never met that kind of patient, right? So how do you now like make them comfortable, you know, work through an interpreter, work through this, how do you examine and all of that? So these are all parts of the social skills, which I think the observerships and conferences and interacting with our volunteer faculty can really help you regarding that. Other people have kind of talked again about timeline. I will emphasize again, roughly speaking, if you're hearing about USMLE for the first time, give yourself 24 months. Basically, if today is the first time you hear about USMLE, give yourself 24 months. You need 6 months to clear step 1, 6 months to clear step 2, 6 months to clear step 3, and 6 months just to put your package together. So that's about 24 months. Or the other way is to say, hey, today I want to join the residency in 2028. My preparation needs to begin at a minimum 2028 minus 2 years. That is a more realistic. I have other people, oh, I want to do it in 12 months. Oh, I want to rush and whatever. You cannot rush it. There's no way you're going to clear 3-step exams in 12 months, right? And 15 months doesn't really cut it. It doesn't mean anything. Remember, your timeline is linked to the U.S. graduate medical education calendar, which, as we said, you match in March, which was yesterday. Yesterday was match day. You're going to start exactly 3 months from now, which is going to be July 1st. That is the rhythm in which. And then after that, after 2 months after July 1st, the cycle begins over again, right? So basically, you just have to decide which July 1st would you like to join for your graduate medical education. So hopefully that helps. There was somebody saying that they're like MD5 and they just heard that. One thing, maybe just to mention it so we can get it out of the way, is the issue of visa and whatnot, just to maybe give them a little bit about the visa situation, because they may be reading a lot of stuff in the news about visa and all of that. J1 versus H1.
So, I mean, the key thing is international medical graduates are an integral part of the US workforce. That's why they pay you. They don't pay you because they love you. They pay you because you are there, you do the job, you see the patient, you make it easier for the attending, and American population get the healthcare they need. And so, as much as you hear the fracas and everything else, I believe the J1 visa and the H visa will continue to be there. So J1 is a training visa. And J1, you need to get a statement of need from the Ministry of Health saying like, oh, this guy is applying for psychiatry. Yeah, we don't have enough psychiatrists and we can use him. Or this person is applying for radiology. Yeah, the country has 20 radiologists and we need more radiologists and like whatever. And so, but J1 as a training visa, it has a caveat whereby you need to go back to your country for at least 2 years before you come to the US, because the aim for them is to train you and to go back to your country. But there's a go around everything. So people will finish and they decide like they want to stay. And so that's where they apply for J visa waiver, whereby they work in places which has medical need. So when you say medical need, even New Haven, which is next to Yale, is a place of medical need. So it doesn't mean medical need you are going to somewhere Mtipwindi where there's no tarmac road, there's no internet, like you are drinking water from a well and you are walking around, hyenas are passing by you. It can be as suburban and as townish as it can be. So it's just the area they don't have enough physicians and it's classified that way. It varies year by year, depending on Health and Human Services Department classification. And so you work there, and that's where you waiver your visa, and then you can transition. So it's not really that it's a sentence, like people go, very few people, if they go, they planned to go even before they did that. And so it's really open. Then H visa, you have to have step 3 before you get a H visa. And just to reemphasize, you don't need step 3 to apply for residence. You just need step 1, step 2, and the English exam. You get ECFMG certification, you can apply for residence. But when we talk, we'll tell you like if you do step 3, then it shows you are ready for full residence training. Remember, program directors, when they take you in, they want you to graduate. It's our goal to have you graduate. So if you don't, if let's say your marks was borderline, and then you fail step 3, you cannot graduate before you pass step 3. And so if you come, you have passed step 3, what are you telling me as an associate program director? You are ready for full residence training. So for you as an IMG, as you're waiting through, because you are not in the tight schedule of the US residents where they do in their second year, they do in their 4th year, and then they apply, and they don't have real time. Well, for you, you have some kind of time. You are not mandated by the timeline they work with. So when you do your step 3, you make yourself stand out better, and that's how it goes. But I mean, that's the essence, then that's the benefit, and yeah.
Got it. Got it. Great stuff. So which, just a comment here, some chat around like where to get the book and whatnot. I think the book is around like $60 and whatnot. And that may be a challenge and so forth. So here's my take. I'm old school. I believe in books, physical books. Because now you have a physical copy of what it is that you read. Yes, you can download versions. People put a link there that where people can go find a version. Maybe the versions are back to like 2017. Listen, you're gonna read this book for like 4 years. Please pay the money and get the book. Now, I don't know how we can get those books, like the 2025 book, to Amazon, whether Amazon delivers to Tanzania and whatnot. Ask somebody in the US to buy it for you and send it to Tanzania. Figure it out. But basically, it's well worth the investment. One, the medical knowledge doesn't change as much. Very subtle things change and whatnot. But again, you're investing in yourself, right? All of you probably have the latest iPhone. You guys probably have the latest Android phone. But you must have the latest tool for your medical profession, which is the USMLE first aid book, right? So that is $60 versus your phone, which is $600. So please, I think of this as an investment. Do not think of this as a cost, okay? If you think of the fee as a cost, that is going to price you out, right? You are already paying, right? And anything cheap is costing you in other ways. So again, you downloading like the free copy is costing you in other ways. Why? It's not as easy to annotate PDF books. It's not as easy for you to retain digital information, in my opinion. I do feel that like digital information, unless you're sort of interacting it actively, meaning like, let's say creating Anki cards, creating flashcards and whatnot, is very difficult for people to process digital information that they read online or they read on a PDF. So I do believe so far, certain core books should be bought, because then you can really kind of like really engage with that to a point where there is a physical memory of just reading a book and understanding, hey, that chapter is somewhere here. There's something physical that is getting lost in the digital space. But that's my own opinion. If you are, you guys are new generation, digital may be the way, videos may be the way, podcasts may be the way. I don't care what you do. But the point is, make sure that knowledge is sort of like ingested in you and really becomes like part of what you do and whatnot. So I don't really have suggestions for local in TZ, but there are enough people in the diaspora that you can ask them to kind of get that book for you. I also heard some say something.
Actually, just to add,
Yeah.
they have in Tanzania, they have made it very easy for you.
Okay.
There are these guys who are advertising all the time. They call themselves Silent Ocean. They say, you know, you can get anything from anywhere in the world. You order, you deliver to their warehouse with their address, and they deliver to you. So one of the things I'm going to make one effort, because I know one of the guys who's the director here in the US. I'm going to talk to them and I'll tell them I have students who wants to buy books. How can they direct and what to do? What are the contacts? And I will make it for you so that you can get the books. You don't need to know anybody. You just go through a system and they deliver.
We can pre-order them for the TAMSA General Assembly.
Yeah.
So
I mean,
if you prepay, we just ship like 200 books and whatever. And then that way, if you paid for your book, we basically just deliver it, somewhere in August and whatnot. So there was another comment here. This trended a little bit, I think like a year or so ago, about whether the World Directory of Medical Schools is going away. Somebody here, Osman from AKU Kenya, was saying something like I guess Kenyan Medical Professional or something, KMPDC, I'm not really sure what that is. It is now no plans to renew the country's membership. I guess at some point the membership will expire. Have you heard anything regarding that? There was some comments regarding that previously, and more like rumors than anything, but I don't think it really came to fruition.
Yeah, so they are trying to do it, and I think the system they couldn't integrate, but guess what? As I said, they need IMGs, and so they just went to what is working. I don't see them shutting the door for people. They will find a way around, just the way they started. Kind of, they're gonna evolve, and countries will have to apply. They'll have to pay some tons of money. People are freaking out, like I cannot apply. And the people are applying and they're getting their USMLE numbers and they're moving on. So, it's not there.
There was also a little bit of like misinformation, because I was saying like only certain countries in Africa will be allowed. So for example, they were saying only Egypt or South Africa will be, only those medical schools will be recognized. And so therefore, like some of the medical schools in sub-Saharan Africa won't be recognized and all of that. I think a lot of that was probably like false information, and maybe they were trying to discourage folks from applying. By the way, there are hundreds of like folks from like Egypt and elsewhere sort of like applying and getting into these programs and whatnot. So don't be fooled. Basically follow the process and kind of keep chugging along. And this is why we feel it's our responsibility to make sure that people have accurate information. Now, somebody asked, do my academic performance in medical school matter? Absolutely, right? We always have to remind people, GME training is academic. Right? It's an academic program. So absolutely, anything academic performance is going to help you. So when you do well in your medical school rotations, that is going to help you. And we actually, at some level, they do look at your medical school transcripts, right? You can't get all like D's and F's and have a really great USMLE score. That's also not going to help you either, right? So the idea here is that by studying for USMLE, that should help you. That should supplement what you're already learning in your medical school. So automatically your medical school GPA should be enhanced by you studying for the USMLE exam. And so therefore these go hand in hand. We received this question also on the college application thing, where people are asking, hey, should I just worry about SAT scores, or should I also worry about my high school scores? Absolutely. Yeah, you can't get like C's and D's in your A levels and be like, oh, I have a really great SAT score. It doesn't matter. It doesn't work that way. Think of the USMLE as just one data point, but at least it's a data point that's uniform across everybody applying for residency training. That's the beauty of the USMLE, right? So your school can decide they give you all A's, right? For whatever reason, they can just decide, hey, everybody who gets a 50% in our school, we're going to give them an A, and everybody is going to look like a superstar. That's great. But those people, there's no way they're going to crack the USMLE exam at a high level as well without preparing. So that's where you can think of the USMLE as a leveling exam, but obviously academic performance will help, volunteer opportunities help. Volunteer opportunities help you in providing evidence of leadership. So when you show that you are being a leader and basically able to be impactful, that is also very attractive to residents, because usually those people have the initiative and the stamina to kind of persevere through residency training. Remember, residency training has call, has a lot of things that you're going to do that are not comfortable, right? That are not convenient. You may have to work on holidays. You may have to work like extended days. You may have to, some days we may have to do a lot more. Some days we'll have like a snowstorm, right? So you're being asked to do things that are above and beyond. And usually people with sort of like leadership or extracurricular experiences have that flexibility and stamina to do those kind of things. Yes, recording will be sent and all of that. Why should, okay, so that's great. I think we've covered most of the questions, and I think now we're kind of like have the last 15 minutes so we can begin to kind of like wrap up. We don't need to keep everybody here. If there's anything that we have not covered, maybe people can speak up in the next 5 to 10 minutes, and then we can begin to wrap up our session.
Or if anybody has a follow-up question, depending on how we answered your question, I mean,
can you elaborate on fee
that's
charges?
the essence.
Maybe it's just speak a little bit about the expected fees. I think we mentioned 160 for the document verification, and I think the exams also have a fee. I don't know whether the 1,000 is per exam.
It's around $1,000.
Per exam?
$1,000. Yeah.
Per exam?
Per exam, yes.
Per exam.
Just know there are 4 testing centers in Africa, and 2 of them are in East Africa. One in Nairobi, one in Kampala, and we have one in Ghana, Accra, and another one in South Africa. So for East African, you take a bus and go and take your exam. Other countries, they have to fly, they have to get a visa, they have to do everything else. So it has been made easier for us people from East Africa.
Okay, great. So in short, I was just people just to kind of break it down here. So roughly speaking, we're talking basically we have the document verification, which is like 160, and then basically they need about $3,000 to clear all 3 steps. So roughly, you're talking about 3,500.
And I mean, what I will add, we talk a lot more in the 201. This really is meant to wet your legs and let you know what's going on. Yeah. And the way, I don't want you to think of the cost like I need $3,500 in my pocket to start the exam.
Correct.
Because this is spread over 2.5 years.
Correct.
You know, when you start working on it, you are putting your effort, you show, you know, you making the step 1, you pass, you're looking, people will be even come to help you. So don't bother yourself when you are there, you're stuck in the first step. I don't have $3,500, I'm not taking USMLE.
Correct.
You don't need, you know,
correct.
So have a positive mindset, you know, start knowing this is what you'll need, start putting your effort, connect it together and move on.
Correct. Yeah. And again, you can even ask, we had some colleagues who came on the call who actually their family invested in them, right? So you can borrow this money from your family members, right? So if you show your family member that let's say you had the 160 to do the document verification and you were able to get $1,000 for the step 1 and you passed. If you come to me and you pass step 1 and I'm your family member, I'm going to sponsor you for step 2. Right? So it's basically the gift that keeps giving. If I see that you have potential and you're performing, we're going to invest in you. But if it's like, hey, you don't have a USMLE number, you haven't done anything, you're getting D's in like your first and second year, why am I going to invest in you? Like, why should we invest? But you have to ask yourself, would you invest in you? Right? If somebody came to you, would you invest in that person? And then you have to make yourself that person that people want to sort of invest in you. So again, think of this as an investment, and literally that money is basically a fraction of what you're going to be paid when you actually complete the match, when you actually match into residency. That's gonna feel like a cent on the dollar. So it's just yeah. So again, a lot of this is mindset. And again, you know, everybody's circumstance is different, but we're here to kind of like make sure that you have all the information available to you. Interview costs and so forth. So again, with all of these things, as again, we want to kind of like, emphasize, is that when you show potential, people are going to be more willing to kind of host you, right? So when you show potential, then people are like, man, you crushed that step 2, you got a 255. I guarantee you, there are like doctors in the US who are Tanzanian who will be like, come over and stay in my house. Because we see potential. We're going to like host you. It's not a big deal. Come to Atlanta. You will stay in my house for like 3 days and go do your interview, like whatever, right? Because we know you are going to basically succeed. You've proven that you're a competitive candidate. So the really key component of all of this is to do everything you can to be a competitive candidate. If you're not competitive, then all of these excuses are going to come up. Oh, I don't have money for interviews. Oh, I don't have money for step 2. Oh, I don't have money for like the first aid book. Oh, whatever. There's always going to be a cost. There's a cost to you going to medical school right now, right? You already committed 5 to 6 years of your life. That's already a cost right there, right? So you're paying one way or the other, you're paying. So our job here is to make sure that, hey, you're getting the best bang for your buck. Are you having the best medical school experience? Are you having the best medical education that you can? Are you getting the best information about USMLE that you can? And are you getting honest information about this stuff? And that's the only thing we can do. And then you gotta do your homework, man. You gotta do your homework. And again, if you do all of these things, with time, we're going to have the critical mass that's going to transform medical practice in East Africa, right? This is how the Filipinos have done it. This is how the Indians have done it. This is how the Chinese have done it. There was a cohort that came and trained in the United States, and they went back in waves, right? So it can't be like 1 or 2 people going. It's going to be like 500 people come back to Tanzania and trained in the US. So suddenly we're all speaking the same language. We all went through the same training. So we say, hey, this is going to be the standard here. Suddenly we can sort of control it. But if we come like Frank Minja comes and says, 1 in 100, it's like, who the hell are you, right? Whatever, right? So people are just going to ignore you. But if 50 of us show up at Muimbili, we're going to change whatever happens there, whether they like it or not. Because now we have what's called critical mass. So the job that we're doing here, hopefully we're recruiting some of you, that in 10 years we will have that critical mass. When I say Israel, we need a dermatopathology lab at Muimbili, it's like, sure, he will have his fellows under him. Say, yeah, we'll show up there with like 15 people deep, right? We can like train and take over the lab, like whatever you want, so that now you can begin to do things. But if you don't have this fundamental basics, then it becomes very, very difficult for us to kind of, build sort of on that. So would you recommend East African high school students aspire to match it and pursue medical locally, or go to the US and do undergrad, med school? It's an 8-year pathway. Excellent. Great question. So that's a great question. So I'm a product who did basically a high school in Tanzania and then did the sort of 8-year pathway in the US. It's a little bit rough, but it has a lot of its benefits and so forth. So there are many ways to enter the US system, if you will. So you can come here from middle school and do high school in the United States and go through college and so forth. A lot of those choices will depend on your immigration status and your financial status. Okay? If you happen to have a green card, I would say stick to the US system as early as possible. That will be, right? So for whatever reason, let's say you were born in the US, some of you may be US citizens, whatever. If you have US immigration papers, that's not an issue, green card or passport, I would say come to the US as early as possible, because it gives you the best chance to integrate into the US system, right? Meaning you really understand how America works. So the earlier you join, the earlier you sort of understand that, and the earlier it's going to be easier for you to navigate. Now, if you do not have the US immigration papers, right, the next best thing is to apply via scholarship, right? So if you're applying via scholarship, then come as soon as you get your scholarship, right? Because if you're competitive enough for a scholarship, then you're going to be competitive like throughout like the rest of your career. So that's fine. So come as early as possible. Now, if your family is financing everything, right, and you know that at some point you want to come here for US medical residency, I would say do medical school in East Africa. That's what I would do. If my family is paying for absolutely everything, I would say get into the best medical school in your country, do medical education there. During medical school, have your family pay for you to come to conferences, have your family pay for you to come for some observerships, have your family come and give you exposure. That's how I would play the game. And then come here for residency training. That's how I would play it, basically. So if I'm now like a high school student and my family can really afford for me to come to the US and whatever for like, those observership kind of like stuff, then that's what I would do. Because again, if your family has to pay for college, which is very expensive in the US, that to me, I think is very expensive and not realistic if you're using Tanzanian earning to pay for US education. I think it's very expensive and maybe not warranted. But that's my own bias on it. James, I don't know what you think about that.
No, I don't think you could have answered it much better. And actually, I've had people call me, this is very nice. I want my child to kind of come to the US to do further training. Can they come to medical school? And like they're finishing high school in Tanzania. They are not, they are Tanzanian. They don't have US papers. And I'm telling you, the road is real. I mean, Frank kind of downplayed it. But what I'll say is, for me, I know a lot of people. But I tell you, I can count with fingers of my hands Tanzanian who finished high school in Tanzania, came to Tanzania after high school to train for college and go through medical school. So it's a tough route. It's very competitive, and just to put it in perspective, in 2010, I was working with University of Medicine and Dentistry of New Jersey in 2010. And they have 120 slots. It's not in the top 100 medical school in the US. In 2010, they got 12,000 applications for the 120 slots. So they recruited 1% of the applicant. 99% they couldn't get in. So it's very, very competitive. Frankie did not explain the thing of it. But when you come to residence, people are matching. I mean, people are matching.
Tell them how many IMGs in the match.
So we had 4 people who we know were applying, and 3 of them matched this year.
No,
so
but also in total, like in the US, I think you had the number last time, like 40,000.
Yeah. So
of the slots.
In the March last year, this year they matched for around 42,000 people. Okay. And out of those 42,000 people, 19,000 people were IMG. And this is coming from out of like 36, almost 38,000 IMG who applied. So they are matching almost closer to 50%. But going to medical school, it's 1%. So, so it kind of, when you come towards the top, it has so much. And especially when you know early and you do the ABC that you need to know. You guys, you have advantage of information. So you just take the information, you follow the ABC, you'll match. People have been talking like, oh, if I don't go for elective, am I total loss? No. I have somebody who matched this year who did not come to the US at all. He wanted to come to do step 3 and do observership, but he was denied a visa. He applied from another country. He went ahead, put ahead the application. Guess what? He matched. So because he has demonstrated, he has met US trained where he is, he has letters from US trained physicians, and he can demonstrate, and that's it. So don't shortchange yourself, go for it, and you should be fine.
Awesome. Great stuff. I think somebody else, can you share any conference details that we can attend with TAMSA so we can know if any opportunities? Are you asking about the TAMSA conference, or are you asking about which conference? I'm not really sure how that question is worded.
So, I mean, the
US conferences. So US conferences, basically, I would say conferences that you can submit something. Okay. So there are several conferences that will basically allow people to submit abstracts and so forth, right? So let's say you're an MD3 student and there's like a clinical case that you want to present and so forth. So these are sort of the opportunities, and they're going to be local to where you are. But always look for opportunities that allow medical school students to submit abstracts and so forth. So I think that's how I would do that. The tricky thing about US conferences is the cost of attending, right? So we are sponsoring now our colleagues to come here to the US to come for interventional radiology conferences, and it's anywhere about $3,000 for the conference. Now, I would not come to the US for 1 week, okay? But if you're able to combine an observership or clinical elective and so forth with a US conference, to me, that would be like the best way to do it. I wouldn't spend $3,000 to spend a week in the United States. There's not enough time to kind of gain it. So really the conference should be in addition to something else. And by the way, there are many conferences on the continent, right? So right now, there may be conferences in Tanzania. You can volunteer. Hey, can I volunteer for that? In Tanzania, there are always medical conferences or like whatever, nephrology, cardiology, what. Ask to volunteer. Hey, let's say you already know that you may be interested in neurology or cardiology or gastroenterology. If you see something here about liver cancer, ask the conference. Hey, can I please volunteer for this conference? Hey, do you guys have any like reduced admission for medical students and so forth? I used to do that. Even me, when I was a medical student, when I can't afford to go to conference, I would email the conference organizer and say, hey, do you guys have reduced fees for medical students? And most times I'll be like, come in. They're like, you're just a poor medical student. Who cares? Come in, right? It doesn't matter. Like, you're not going to cost us anything. But the beauty is when you go as a medical student, you get to be in the room before you're actually being asked to present. So now you get to just sit back and watch the game being played. It's kind of like being invited to the Arsenal, sort of like, like locker room. Hey, this is how, you hear how the strategy is kind of like going down. But you're like a junior kid, like a 5 or 6, 7-year-old. That stuff kind of like changes your mindset. So you're like, these guys are just like humans like me. This is like a jama, this is just like my uncle. Hey, this is just like, he's just like my brother. Then you now begin to understand they're just humans like you. We're just people like you, man. It's not like this whole thing. Because sometimes the professional thing sort of separates you. Like, oh my God, this guy's like unbelievable. Like, whatever. Like you make people like sort of like not human. But when you get exposed to them early, you can begin to sort of relate to them. Like, you know what? There's something about that person that sort of I relate to. You know what? In 5-10 years, I can be that person. And that's why, we started this talk with, I think we probably should end there with just sharing the stories. I said very briefly about the candidates that we had sort of shared. But if you can please just say a little bit about the candidates we have in the PowerPoint, and we can use that to close, because really seeing is believing. And I really think that it's important that these stories be told so people get over that whole thing of like, it's not possible, because that's really one of the things that we really hope to kind of dispel that. So I'm going to share that. So Ignas, you can share a few words about these guys, and we shall stop in exactly 10 minutes. So 10 minutes we'll have to stop because I have to go to my next engagement. Karibu, Dr. Ignas, just share like 1 minute about each of these candidates, and then we can close the session.
Oh, so
just introduce them.
Eligape Urasa, and Eligape Urasa marched into pediatrics. Actually, it's the candidate who marched without stepping in the US. So he'll be coming for the first time to start his residence. So
nice. What was his journey again? I can't remember. He finished where?
He was born and grew up in Arusha. He studied at KCMC.
Yeah.
And yeah, he studied at KCMC and currently is practicing in India. But then that's where he was, and he did his exams, and he'll be crossing the continent and coming over to the US.
Karib sana,
and he'll be doing pediatrics.
Awesome, fantastic, phenomenal.
And then this is a colleague from Uganda. Is currently doing pediatrics, and yeah, so was
that Semakula or something? I noticed the name.
Yeah, Semakula. Yeah, it's Dr. Semakula. So right, he's in Driscoll Hospital, Corpus Christi, Texas.
Awesome.
Doing pediatrics.
He's now PGY, rising PGY 2?
No, he's an intern. So in July, he's gonna be PGY 2. So it's gonna be
awesome. So he matched last year.
He matched last year.
All right. So all right, awesome.
Yeah, and this is Moza Abed Ahmud. She's born and raised in Kenya from Mombasa. She's now in internal medicine PGY 1 in California. She's aspiring to do oncology. I knew Moza through her aunt, who was a pharmacist and helped my wife to get her pharmacy license in North Carolina. And I've been kind of mentoring her from PGY 1. So she came here to college. she didn't match into she didn't get a slot into a US medical school, so she crossed and did her medical training in the island in St. George University. But then she finished her medical school there, did her USMLE and matched, and she's doing her residence. And this is where to show like it's really competitive to get into US medical schools, but people have alternative routes and they can do it. And so where you are, it's the right plot. I mean, whoever trains outside the US is called an international medical graduate, even if you are a US citizen. So international medical graduate, IMG, is not just for non-US people. It's anybody who trains outside the US, continental US. And that's almost makes almost 50% of people who match into residence. So there's a big avenue, there's a big chance just to get ready. So Mabus, Mangaro Mabus is now PGY2. It's gonna be PGY3 in July. So born and raised in Tanzania, Mabus, I feel like he came yesterday. Born and raised in Tanzania from Mara region, you know, he did his medical school in Cuba. Actually, Mabusi met me through my professor of anatomy, neuroanatomy, Professor Mtui. Professor Mtui went to school with his uncle. It was when we are not doing kind of reaching out to everybody. His uncle went to school with Professor Mtui and was like, "Oh, I have my cousin who is really interested in doing medical school in the US. Can you help him?" And Dr. Samtu say, "I didn't do this, but I know a guy who is in doing residence and he can be very helpful." So Professor Samtu reached out. "I have this guy in Cuba, he wants to do USMLE. Can I give him your number?" "Yeah, go ahead." So we started chatting with Mabusi. I saved him in my phone as Mabusi Cuba, you know, but he's aspiring to do critical care. And so he wants to do ICU critical care. And so, yeah, he'll be applying. And hopefully he'll join critical care. So this is Otioli Wambalaba. He's originally from Kenya, went to University of Nairobi. Otioli was born in the US, and when he was 10 years old, they moved back to Kenya. So he finished secondary school, high school in Kenya, went to University of Nairobi, and then did his exams. And so I was interviewing, and I met Otioli in the interview, like, "You're applying." He was a very strong candidate. I mean, we matched him. We are lucky to match him. He's thriving very well and doing great things. So from Jamhuri ya Kenya, this is Magacha. Magacha, Hesbon Magacha is originally from Tanzania, born and raised, went to Tabora School for high school, and then he went to MD in Cuba. So he's doing now is PGY2 in internal medicine in East Tennessee State University. This is a picture of him with his fellow intern residents, and so he's aspiring to do gastroenterology and then interventional gastroenterology, you know. So yeah, he'll be a senior in July. Pili Kamenju is graduating this June. So she's now PGY3 at St. Vincent Hospital doing internal medicine. Her mother is from Kenya, her father is from Tanzania, grew up in Kenya, then went to Tanzania for medical school, but she's Tanzanian, you know, and I think she has just signed her attending contract. She's gonna work as a hospitalist, I think, somewhere in the middle of the country. She's excited about it, you know, and it's just like that. She's done. This is Barbara Odak. She's now PGY3, the one who have cycled here. She's originally from Kenya, born and raised, went to Kenyatta, Jomo Kenyatta University. So she's now doing internal medicine, preventive medicine in my program in Griffin. She's now doing her year of MPH at Yale. She wants to do cardiology, and yeah, it's one of those people. She's gonna be PGY4. This is Amir Mbonde. And Mbonde is a Tanzanian name because his grandfather was from Rufiji, so was a Muslim cleric teacher, went to Kenya and then to Uganda, so they settled in Uganda. So he travels with the Ugandan passport, and sometimes they ostracize him like, "Are you Ugandan?" Whatever, "I'm Ugandan." So he studied in Barara, and when he was doing his residence there in internal medicine, he met a neurologist professor from Mayo Clinic in Arizona. And, you know, he demonstrated interest. "I like neurology." I say, "Yeah, do your exams and you come." And so he went through, did his exams, and he matched in neurology in Arizona. So he did Arizona there, and then he went to Harvard, MGH, to do neurocritical care. And then he kind of did epilepsy again in Mayo. Is now an attending neurologist in Augusta, Georgia. So he's doing neurology from Uganda, and you know, is a full-fledged attending in neurology. So this is Israel Kasago. Israel Kasago is originally from Arusha, so he's a Chuga boy. He studied in KCMC, and then he came here to do pathology. Israel and me, we studied together. So we matched together in the same year for residency. We are kind of, you know, pinging each other, like, how are you doing? When are you taking your exam? You know, pacing each other. And you need to find the right crowd to vibe with. You know, you are working with people who are kind of, you know, they are pessimistic, you know, they are kind of, you know, this does not work. Yeah, that's what you'll go with. Work with people who you are thinking the same. So he did fellowship in molecular pathology, oncologic molecular pathology, and then, of course, dermatopathology. So he's working as a dermatopathologist in Michigan. So, I mean, and that's the thing, you know, people at home, they think pathology is just doing, you know, cadavers and everything. People do a lot of things in pathology. So he came to visit me. This is my son in the middle, and me and Israel. Just as he was finishing and we are talking, you know, now we start talking. And as an attending, you know, you're going to make more money. How do you start investing? You know, retirement is real, you know, and all those things. You know, mentorship does not stop there. You keep talking and, you know, pumping each other, helping each other, and see people succeed. And that's the essence of it.
Asante sana, Ignas. I think that's a beautiful note to close. I think hopefully everybody now is a believer that all of this stuff is possible. Thank you so much, everybody, for spending your Saturday with us. Really appreciate the questions and the engagement. We really need to switch to another engagement here. So again, asanteni sana for your engagement. What is the process of getting the U.S. after U.S. scholar? Considered extremely difficult. The answer is yes, but it is still possible. But the chances are fairly slim. So again, thank you so much for joining in. Hopefully this was informative for our colleagues in TAMSA. Thank you for the colleagues in Uganda and Kenya who are tuned in and so forth. So we're really glad that you tuned in. We will share the recording. I'll also share the AI summary of our little talk. And Dr. Ignas, I don't know if your slides, you want to share them as PDF. We can also share it with everybody who registered for the
I mean, the slides, they don't have much. I mean,
Yeah.
it's the meat in the slide because we just see lines. I've never shared them. I don't care. Nothing, everything is online. But
Yeah.
really the key thing is listen to the talk, kind of take your notes, make your action plan and follow through. Don't follow in the statistics and be the 93% who don't do anything. So far, that's the number, and I'm working on it. I will publish that thing. So don't be my
Asanteni, cool. I couldn't appreciate you more. Thank you guys for joining in. Thank you for tuning in. Until next time, Ajamani, all the best. And on your journey to become the best medical doctors you can be. Asanteni sana na washukuru.